wiring. And this is another case from CCT meeting. This case was conducted by Dr. Suzuki, mid-delay occlusion like this. And he also started with Antegrade wiring with field XT. However, first attack created a subintimal space. So he left it there, and he advanced another field XT. So parallel wiring with double field XT. And after careful manipulation, he got septal branch like this, one of the field XT. Of course, he left it there, and he advanced another field XT carefully into the parent vessel, and it was finally successful. And this is the final result of this case. And this is another example, RCA proximal occlusion. And this case was conducted by Dr. Mitsudo. And he also used a Corsair with field XT first. But the field XT created a subintimal tracking. So he moved to a parallel wiring with Conquest family. And he got distal to lumen with field Conquest family. This is the final result of this case. So now, of course, parallel wiring is now standard technique in the Antegrade approach. And but sometimes IVAS guidance also provide good information. This is distal RC occlusion, but reattempt case. So very short occlusion up to bifurcation. However, first attempt failed, and I tried second attempt with Miracle 3. However, it could be easily advanced into outside the vessel like this. So in those cases, very in short occlusion, probably the entry point is not good into the occlusion. So we can check the entry point of the first wire. If there is a big side branch enough to advance IVAS caster like this, and this is IVAS image, and you can see an entry position here. So this position is not so good because it's very close to the side branch like this. So from this point, usually first wire go into a subintimal space. And you can imagine another case with, commonly you can see in short occlusion in the mid-LAD after diagonal branch. So in those cases, probably first wire, the entry point wire was long like this. So the entry point should be around the center like this. So this position in the angiography, opposite side of the side branch between the first wire. So we should go the second wire with the second wire toward this direction, opposite side of the side branch. So I advance a Miracle 6 as a second wire, and then the second wire parallel Miracle 6 easily advanced into the distal to side branch. So this is the first wire in fourth channel, and this is the second wire in the true channel. So maybe it should be called IVAS guided parallel wiring technique. So sometimes IVAS examination from side branch provide a better information when first wiring failed. And this is the final result of this case. So now IVAS guidance from side branch sometimes we use. However, if parallel wiring also failed, what is next? And it used to be IVAS guided penetration from subintimal space. And like this, so if you create a big subintimal space, only IVAS can tell the cross-sectional information, and sometimes you can get the collapsed true lumen under the IVAS guidance. So this is IVAS guided penetration technique. However, basically this procedure is very, very complex procedure. And I will show you one case. I'll see a very long occlusion. And after unsuccessful parallel wiring with the stick wire, and you can see some minor perforation, and the wire was in the subintimal space. However, this is IVAS catheter, and IVAS clearly tell as the cross-sectional information like this, and you can see a collapsed true lumen here. So this is IVAS catheter and the adventitia, and this is a collapsed true lumen. We cannot see any angiography only. So this is a great dissected force channel. And so the next step we have to do is to advance the second wire into the collapsed lumen. So I advance the second wire conquest under the IVAS guidance. And finally, it creates another channel tracking, and IVAS image confirms the second wire confianza in the collapsed true lumen. And this is the final result of this case. So it used to be, IVAS guided penetration used to be a last alternative in the CTO PCI. However, now we have a retrograde approach. So now this is the last 5 years of my experience, and I frequently retrograde approach was established in 2005. So from 2005, I frequently use the retrograde approach, and according to the increase of a retrograde approach, success rate also increased. However, you can see sometimes I use the still branch IVAS examination. As I mentioned before, like this. However, now subintimal IVAS examination for penetration very, very rarely used. And last year, I have no case with IVAS guided penetration. So, and why? Because IVAS guided penetration is not so promising. Overall success for 5 years around less than 70%. So compared to the retrograde approach, IVAS guided penetration is not so promising. So that, and also very complex. So that now we rarely use IVAS guided penetration. So usually we move to retrograde approach after unsuccessful parallel wiring in majority of case. However, of course, if a retrograde approach failed, of course, still IVAS guidance. IVAS guided penetration is the last alternative in total CTO PCI. However, but in the future, what is another option? And this is a case I experienced a few months ago, and a very, very calcified LED occlusion, like this. And you can see some antegrade flow, so that it seems to be a